And I want to welcome everybody to the first internal medicine grand rounds for this academic year. And what I've decided to talk about are emerging therapies for hyperlipidemia. There are some medications that are likely to be available to clinicians for us to use in the relatively near future that work by a very unique mechanism that I think very few of us currently know much about. So I wanted to bring people up to date. In preparing this grand rounds, what I did is I went to the evidence-based literature, to reputable journals like Circulation, New England Journal, Lancet, collected what I thought was the best information, put together my talk. And like any CME talk, I've got to provide disclosures of any potential conflicts of interest. So I do own a number of stocks across many different sectors, and during the next hour, I will be talking about medications either available or in production or under investigation produced by these pharmaceutical companies. So let's begin to talk about cholesterol. And I have to give you my objectives, and what I'm showing you now are not my objectives, because you all know that hypercholesterolemia leads to heart disease. We want to lower LDL cholesterols to reduce that risk. We're aware of the many clinical trials, particularly with statins, as agents that are effective in reducing cardiovascular disease. And based on these trials, goals, guidelines have been developed for us to manage patients. These are my objectives. I hope by the end of the hour you get a better appreciation that if you are going to intelligently manage patients with hyperlipidemia, you've got to think past, is it just the cholesterol, is it just the triglyceride, is it both, but to have some basic understanding of lipoprotein metabolism. I'm going to review the mechanism of action of statins, and then to discuss some of these emerging therapies focusing on the PCSK9 antibodies, talking about antisense oligonucleotides and inhibitors of microsomal transport proteins that inhibit VLDL production, and if time permits, mention the cholesterol ester transfer protein inhibitors. So these are the culprits, the lipids, cholesterol, and triglyceride. They're hydrophobic. Remember that triglyceride is simply a 3-carbon glycerol backbone with 3 fatty acids condensed to the carbons. And as we talk about triglyceride metabolism, they're broken down into monoglycerides and they're broken down into free fatty acids. Now, because of the hydrophobic nature of lipids, they circulate in the aqueous plasma incorporated into these large spherical particles, the lipoproteins. The basic structure of lipoproteins is that they have a core of very neutral hydrophobic lipids, cholesterol ester and triglyceride, surrounded by a shell of more hydrophilic lipids like free fatty acids and free cholesterol. And intercalated into the surface are the apoproteins that have important functional characteristics and properties. I want to make mention from this slide, this is VLDL. We'll talk about this to a greater degree on the next few slides, but each molecule of VLDL has each particle has one molecule of apoprotein B100. The metabolism of VLDL is that triglyceride is removed from the core, rendering it an IDL, an intermediate density lipoprotein. Further triglyceride is removed, and here's your LDL, still with one molecule of apoprotein B100. I'll mention also lipoprotein small a specialized form of LDL to which has been attached so-called apoprotein small a. which has regions on it which are homologous with the fibrin-binding regions of plasminogen, and because of this, it can impair activation of plasminogen and reduce fibrinolysis. Now, there remains some controversy whether lipoprotein small a is an independent risk factor for cardiovascular disease, but it does seem to be a risk factor in those that also have hypercholesterolemia. So, a question. A young man with homozygous familial hypercholesterolemia whose cholesterol is 820, LDL is 750, normal triglycerides, and normal HDL. We take his plasma, we refrigerate it overnight. What does his plasma look like? Okay? We don't have an audience response system, but think about what you might choose. And the answer is actually sample B. Doesn't matter how high your cholesterol is, the particles, the LDL, are relatively small, about 200 angstroms. They don't scatter light. They don't cause plasma to look lipemic. This sample of lipemic plasma is from a 25-year-old man with lipemia retinalis with eruptive xanthoma. And so will he have an MI in the next 5 years? Does he need treatment with a statin? High risk of pancreatitis, or is his LDL extremely high? Very high risk of pancreatitis, lower risk of cardiovascular disease. This is a patient with severe hypertriglyceridemia. So let's talk about the exogenous pathway of lipid metabolism. We're ingesting lipids in our diet. Some of the cholesterol is absorbed into the epithelial cells of the GI tract. Triglycerides are acted upon by lipases, breaking them down into monoglycerides and free fatty acids, taken up into the epithelial cells, and there they're incorporated with cholesterol into the chylomicrons. The chylomicrons have one molecule of apoprotein B48. They enter the lacteals of the GI tract into the lymphatic system, out the thoracic duct, into the systemic circulation. As they circulate, they acquire other apoproteins such as C and E and A, and the metabolism of chylomicrons occurs in the following way. Chylomicrons bind to an enzyme on endothelial cells known as lipoprotein lipase. Lipoprotein lipase breaks down the triglyceride into free fatty acids and monoglycerides, which are then transported across the endothelial cells into tissue, principally adipose tissue, where they reform and are stored as triglyceride. So you can think of lipoprotein lipase as an enzyme that moves triglyceride from the core of the chylomicrons into adipose tissue. And if you can envision that they're physically getting smaller in size as this process is occurring. They ultimately reach a size that we term a chylomicron remnant, which is taken up by receptors in the liver. The components are broken down, reutilized, or excreted in the bile. Now, the endogenous pathway of lipid metabolism starts with the production in the liver of VLDL. I've mentioned before, each VLDL particle has one molecule of apoprotein B100. The metabolism of the VLDL is very similar to the chylomicrons. Binds to lipoprotein lipase. Triglyceride moves from the core into the adipose tissue, and they physically are becoming smaller in size. They ultimately reach a size we term the intermediate density lipoprotein. These are highly atherogenic, but in normal individuals very short-lived, because further triglyceride is removed, and now we have an LDL. So the LDL are formed from VLDL by removal of the triglyceride, and the LDL still has one molecule of apoprotein B100. The LDL are then removed from the blood by this normal receptor pathway, which I will focus on the next slide, keeping in mind that this receptor pathway is non-atherogenic. However, if LDL levels are high, particularly if they're oxidized or glycated, they can be taken up by the so-called scavenger pathway into endothelial cells, leading to atheromas. Now, this is a figure that highlights how LDL are taken up by this normal receptor pathway that's non-atherogenic. The LDL binds through B100 to LDL receptors on the cell. It undergoes endocytosis. The endocytic vesicle fuses with lysosomes, breaking down the protein components into amino acids, and free cholesterol rises in the cell. As free cholesterol goes up, three things happen. You decrease the activity of HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. You increase the activity of an enzyme that can store cholesterol as cholesterol ester, and you downregulate, you express fewer LDL receptors on the surface of the cell. And this would make sense. As cholesterol is going up in the cell needs less, so it produces less and expresses fewer receptors. Now, statins, we know, work by decreasing HMG-CoA reductase and reducing cholesterol synthesis. But there needs to be a second step to have a significant effect of statins. What happens subsequently, as the cell becomes depleted in cholesterol, it upregulates the number of receptors, clearing more LDL through the normal non-atherogenic receptor pathway, leaving less for the scavenger receptors. So I want to highlight that the full action of statins requires this upregulation of the LDL receptor. Now, I took this figure from a review in JAMA a few years ago, looking at data, summarizing data, looking at plaque progression or regression, just to make the point that in many studies you start to see plaque regression if the LDL cholesterol level starts to get to 70 milligrams per deciliter or less. Now, you're faced with a patient in the clinic who has hyperlipidemia. Before just reaching for the prescription pad, always consider, is there some secondary cause for hyperlipidemia? For example, someone with a TSH of 85 and a high cholesterol may only need levothyroxine to normalize that cholesterol. So these are some of the common disorders, some of the common medications, and the workup for secondary hyperlipidemia is fairly simple and inexpensive. A good history, CBC, a CMP, a TSH, a urinalysis, tests that we routinely get on patients coming to primary care clinics. Now, here's another question. Here's a 57-year-old gentleman with these xanthomas affecting the Achilles tendon and in the hand. Is this familial hypertriglyceridemia, familial hypercholesterolemia, dysbeta lipoproteinemia, polygenic or primary hypercholesterolemia, most of the patients we treat, or Tangier's disease? What do you want? B. Okay, familial hypercholesterolemia. These are tendon xanthomas, a favorite board question, highly sensitive and specific for familial hypercholesterolemia. These are some of the common and the most common genetic hyperlipidemias, and I'm going to be focusing on familial hypercholesterolemia. Most of the patients, it's due to a mutation of the LDL receptor. A few percent, it's due to mutations of apoprotein B100. And recently we have learned about mutations of PCSK9, and information and knowledge about these mutations has led to a whole new class of drugs currently under active investigation. Of those who have the genetic mutation of the LDL receptor, it's autosomal dominant. There are a huge number of individual mutations identified. Up to date says over 1,600, but they fall into a number of different categories. You can't make a functioning receptor. You make a receptor, but it can't bind LDL. You make a receptor that can bind, but it can't be internalized. Or you make a receptor that can't be recycled back to the surface. So a lot of mutations leading to different problems. Now, in this country, the frequency of the heterozygotes is 1 in 500. The homozygotes, 1 in a million. Now, many of the homozygotes are compound heterozygotes. For example, they've inherited from mom one mutation where you don't make a gene, a receptor, and from dad a mutation where you make the receptor but it can't bind LDL. Very high LDL levels, premature heart disease, and tendon xanthomas. And in those very rare patients that are homozygotes, you may see tuberous xanthomas. These are typical cholesterol and LDL levels in these patients. HDL, triglycerides are typically normal. Extremely high risk of atherosclerotic disease. In fact, homozygotes often don't live past into the 30s or mid-30s. Now, these physical signs of hyperlipidemia, xanthelasma, the corneal arcus, occasionally might lead you to suspect hyperlipidemia, but they're not very specific or sensitive. But as I mentioned, these tendon xanthomas are highly specific for familial hypercholesterolemia. And in the homozygotes, you may see these large accumulations of lipid, typically over the elbows and knees. These are the tuberous xanthomas. Don't see these in the heterozygotes. An important clinical feature is by the time an individual with familial hypercholesterolemia has reached 40, almost all of them have tendon xanthomas. So if you think someone has this disease, look for the tendon xanthomas. They may be visible, but in a more subtle way, if they're not as obvious, run your finger down the Achilles tendon, feeling for nodularity or thickening. Okay, now, how do we treat these patients? The heterozygotes, high-dose statins, and even with high-dose statins in combination therapy, often these patients cannot reach the goals that we would like to reduce the risk of cardiovascular disease substantially. The homozygotes respond hardly at all to any of the medications we have, including statins. Why? Well, think about it. The statins do decrease HMG-CoA reductase, but these patients have no functioning receptors they can upregulate to clear the cholesterol. Highly resistant to any medication. And treatment currently focuses on physically removing LDL. Plasmapheresis every few weeks, or more commonly now, apheresis. Patient sits on a machine for many hours. Every 2 weeks, the blood goes through a column that binds LDL, and the blood with the LDL extracted is reinfused back into the patient. Liver transplant also works. Why? Because over 50% of your LDL receptors are in the liver. So if you give somebody a donor liver with normal LDL receptors, the homozygotes can see a substantial reduction in cholesterol. You can also see the same clinical picture if the receptor is normal, but you've got a genetic mutation of B100 that can't bind to the receptor. And now I'm going to tell you a story that began just over a decade ago. Just over a decade ago in France. A family that looks like they have familial hypercholesterolemia. No mutation of LDL receptor or B100, and what they were identified as having is a gain of function mutation of a serine protease, long name, proprotein convertase subtilisin kexin type 9, PCSK9. If you overexpress this gene in mice, the LDL receptor function goes down and cholesterol goes up. Knock out the gene in a mouse, you have increased LDL receptors, the LDL cholesterol goes down. Then in 2006, Cohn publishes in the New England Journal, I'll show you on the next two slides, an epidemiologic study identifying individuals who had loss of function mutations of this gene. So these are the data for the black subjects in their study. There were 2 mutations identified. In those without a mutation, the LDL was 138. In those with the mutation, an LDL averaged 100. A 28% reduction in LDL resulted in an 88% reduction in the risk of coronary heart disease. In the white subjects, a different mutation was identified, 15% reduction in LDL, nearly a 50% reduction in coronary heart disease. So this comes back to the concept I've laid out before, how LDL through B100 binds to receptors, endocytosis, fusion with lysosomes, degradation of the components, and the LDL receptor cycles back to the membrane to take up more cholesterol by this non-atherogenic pathway. PCSK9 is a gene product that is secreted into the extracellular fluid. It binds to the LDL receptor, and now when LDL binds to the receptor and gets endocytosed, with PCSK bound, the LDL receptor is degraded and can't recycle back to the membrane. So you have fewer LDL receptors. So I would term PCSK9 the statin brake. Statins, by depleting intracellular cholesterol, upregulate LDL receptors, clearing more cholesterol. But statins also increase the activity of PCSK9. So the net effect is that the higher PCSK9 limits the effectiveness of statins. They'd be more effective if it didn't upregulate PCSK9. So how can this information be leveraged to benefit patients, lowering LDL cholesterol levels? Well, the pharmaceutical industry has first come up with this design. Monoclonal antibodies that bind PCSK9 in the extracellular fluid, blocking its ability to bind to the LDL receptor so that the cell can upregulate and express more receptors. It has to be injected. So I'm going to show you studies now. This is from Lancet a few years ago, where one of these monoclonal antibodies was injected every 2 weeks, and at doses of 105 and 140 milligrams every 2 weeks results in a substantial 60 to 70% reduction in LDL. These are patients with high cholesterol on statin treatment. Now, it's an injection. You'd like to give it less frequently. So in this same study, they gave it in higher doses, but monthly. And in the doses of 280 to 420 milligrams monthly, again you get about a 60 to 70% reduction in LDL, although you can see it comes down at 2 weeks and starts to rise up in those second 2 weeks before the next injection. Blum and his colleagues published these data. It was in the New England Journal, I believe, in May of this year, looking at patients who are either on diet, atorvastatin or atorvastatin plus ezetimibe, treated with one of these antibodies, evolocumab, and these are the 12 and 52-week data showing consistent reductions in LDL 50 to 60%. This table taken from that study is pretty dense with data, but let me point out a couple of things. The study design was a little complex because it was a lead-in period. during which these hypercholesterolemic patients were placed on statin, and their LDL decreased so that before randomization to placebo or evolocumab, their LDLs were already between about 96 and 116 milligrams per deciliter. They're randomized, placebo, evolocumab, and at 52 weeks, what I have circled are the absolute mean LDL levels. LDL levels getting down to 45 to 64 milligrams per deciliter. And 82% achieved an LDL of less than 70. A study not looking and comparing patients with primary hypercholesterolemia and those with the more difficult to treat familial hypercholesterolemia. These were heterozygotes treated with a different antibody, but an antibody to PCSK9. And you can see whether combined with atorvastatin or as monotherapy, again about a 50%, 60% reduction in LDL cholesterol. This was a crossover study. Patients were either on treatment with evolocumab and crossed over and were changed, or were off it and changed over. But I would just highlight here, the blue and the green bars represent those who at the end of the study were taking the PCSK9 antibody. So in addition to the data that I've shown you previously, 42% reductions in apoprotein B, 32% reductions in lipoprotein small a, modest 8-9% reductions in triglyceride, nice increases in HDL, 8-9%, and also an increase in ApoA1. If you use it as monotherapy, and that was the design of this study, comparing 140 milligrams of evolocumab every 2 weeks versus 420 monthly. The comparator drug was ezetimibe, and you can again appreciate that there is about a 50 to 60% reduction in LDL cholesterol when these antibodies are used as monotherapy. Now, one group of patients that might be appropriate to consider these drugs would be those who need significant lowering of their cholesterol, who are intolerant of statins. And most of those patients have myalgias. A smaller percent have elevation of CPK. This was a study in which these statin-intolerant individuals were randomized to ezetimibe or the monoclonal antibody. No increase, in fact, one might argue somewhat less, is complaints of myalgias. No increase in musculoskeletal complaints or increased frequency of elevated muscle or liver enzymes. If you have an interest, there's a nice review this year in the Annual Review of Medicine. At the time this was written, over 1,200 patients had been treated with active drug. The number I expect is considerably higher now, looking at the recent reports in the literature. These are fully humanized monoclonal antibodies, which minimizes immune reactions. No clear signals in the numbers treated, again, granted relatively small numbers, but no increased signals for liver or muscle toxicity. Injection site reactions tend not to be a particular problem, but one problem is the volume that has to be given subcutaneously to get these milligrams, hundreds of milligrams of the monoclonal antibody into the subcutaneous tissue. In the Blum study that was in the New England Journal a few months ago, the volume was 6 mLs. And in a number of these patients, they had to divide them into several aliquot, so they were getting 3 2 ml injections or 2 3 ml injections, or some were getting 6 mLs. So that, I think, is going to be a potential problem on how to deliver these drugs to patients. Clearly, I expect these drugs are going to be extremely costly, and we're going to have to carefully balance benefit-cost ratio in considering these drugs, and emphasizing that as yet there are no outcomes data. We're looking at secondary endpoints. We're looking at lipids. We're looking at LP small a. We need outcomes data. Okay, we've been fooled by without outcomes data in the past. I'll show you at the end of the hour something relative to that. Although I think it's reasonably optimistic that these drugs will reduce cardiovascular disease because they work through the same common mechanism as statins. They increase more cholesterol clearance through the non-atherogenic LDL receptor pathway. So why do I think these drugs may be available soon? Well, I get emails every week or so. You find PCSK9forum.org on the internet. Here are the back cover of 2 very recent New England Journal issues. I have no idea what it costs to put a full-color back page ad on the New England Journal, but it's got to be megabucks. Now, the pharmaceutical industry can't sell you a drug that's not FDA approved. What they're selling you is cholesterol is bad, and what they're selling you is we're going to educate you about LDL receptors and PCSK9, which is in there in the small print. So they're out to educate us, and they have clearly a profit margin in trying to educate us. But when you start seeing things like this, it means these are likely to get to the FDA fairly soon, and they must be fairly confident they're going to be approved. Now, what about other ways to lower LDL cholesterol? How about if we can decrease the production of VLDL? Remember, LDL are formed from VLDL by removing the triglyceride. So if we decrease VLDL levels, we will subsequently decrease LDL. So a number of ways have been considered. I'm going to talk about 2 drugs, mipamersin, which is a drug that blocks apoprotein B production, and lomidopide, which blocks an enzyme, microsomal triglyceride transfer protein, necessary for the formation of VLDL. Mipamersin is an antisense oligonucleotide. It's a small nucleotide that has been designed to hybridize and bind to a specific messenger RNA. In this case, the messenger RNA for B100 and B48 as well. When this antisense oligonucleotide binds to mRNA, hybridizes, it undergoes degradation, leaving less to be translated into the protein, in this case, apoprotein B100. So mipamersin is one of these antisense oligonucleotides, blocking apoprotein B production, lowering VLDL levels, and in turn lowering LDL levels. An early study giving mipamersin in doses of, I believe it was 2 and 400 milligrams, well, different doses, but in 2 and 400 milligrams, injected parenterally. Some of these doses were sub-Q, some were IV, over a 3-week period of time, about a 40 to 50% reduction in apoprotein B and LDL cholesterol that persists for many weeks after the drug is discontinued. Data, a 13-week trial, a phase 2 trial, where mipamersin was given in doses of 200 milligrams subcutaneous weekly to patients with primary hypercholesterolemia and those with familial hypercholesterolemia, both heterozygotes and homozygotes. In this group, the dose was 300 milligrams a day. And I want to highlight the percent reduction in LDL cholesterol, 36, 45, 49%. Virtually no drug could ever do this in someone with homozygous familial hypercholesterolemia before. Okay. In addition, moderate reductions in triglyceride and lipoprotein small a. This was a phase 3, 26-week trial, 200 milligrams of mipamersin, again in primary hypercholesterolemia and familial hypercholesterolemia, and now in a somewhat lower dose, reductions in LDL, but not as much as in the 300 milligram dose. One more, this was a 25-week trial, 200 milligrams subcutaneously of mipamersin. Again, LDL, apoprotein B going down about 40%, lipoprotein small a about 30%. And what about adverse events? A substantial increase in injection site reactions compared to placebo, and also a significant increase in flu-like symptoms. But this is more concerning. These are ALT levels, and in the group treated with mipamersin, a marked and significant mean increase in ALT levels. If you come back to the table that I showed you previously, close to a third got an increase in ALT, 10% got hepatic steatosis. Some of these increases in the liver enzymes were quite substantial, although there was no increase in bilirubin. That function of the liver seemed to be maintained. And here in the same study, they divided the subjects into those who were diabetic or non-diabetic. Marked increases in hepatic fat as determined by MRI. That does come down when the medication is discontinued. Now, is this surprising? No, what is this drug doing? It's limiting the transport of fat out of the liver into the VLDL. You get fatty liver. Okay? So this is maybe not particularly surprising, and I took this table from clinicaltrials.gov. It was from this study. 105 patients were randomized in this trial to start mipamersin. 45 had to drop out, 13 because the patient withdrew, and 28 because of adverse effects, mainly liver. So these drugs carry substantial risk. Now, another way to lower VLDL levels would be to administer a drug that inhibits the activity of microsomal triglyceride transport protein. And these drugs will not only decrease production of VLDL by the liver, but the same transport protein is involved in the formation of chylomicrons in the GI tract. This is an oral medication. Okay? So this is lomidopide, and in a very early trial, when doses were titrated up in doses between 0.1 to 1 milligram per kilogram per day, you start to see decreases of up to 50% in total cholesterol, LDL, and ApoB, and these are patients with homozygous familial hypercholesterolemia. Okay. This study was published last year in the Lancet. Patients with familial hypercholesterolemia, those individuals whose cholesterols are typically 600, 800, 1100, It was an open-label trial, phase 3. It was a dose escalation trial. And at the end of 26 weeks, about a 55% reduction in LDL cholesterol and apoprotein B. As with mipamersen, increases in ALT and increases in hepatic fat, and you can consider the same reasons. You're limiting the ability of the liver to transport fat from the liver into the VLDL. These are the data from that study looking at the individual patients. And as I mentioned, it was a dose titration trial, so some patients could only tolerate or were on 5 milligrams or responded to lower doses. Some got up to 60 milligrams a day, with a mean decrease of LDL of 40%. Now, these patients during this trial were continued on their apheresis treatments, the physical means of reducing LDL cholesterol. But just over a third achieved an LDL less than 100. And this is unheard of in these patients. 13% were able to discontinue their LDL apheresis because they were having a sufficient response to the medication. And another 13%, while they couldn't discontinue their apheresis treatments, were able to increase the interval, the time between their treatments. Significant side effects, GI complaints, again, elevation of liver enzymes, over 30%, and significant increases in hepatic fat. Now, mipamersen and lomidopide, despite these side effects, these are actually currently approved by the FDA, but limited to those with homozygous familial hypercholesterolemia for whom we have basically no other medical therapy. It's only available through a very restricted program where the physicians and the pharmacy have to go through a certification process and follow very strict rules in prescribing these medications because of the toxic effects and the costs for a drug which we must consider an orphan drug because this affects only 1 in a million individuals in this country, extraordinarily costly. What about HDL? You know, the good guy. Reverse cholesterol transport, the HDL through a protein, the cholesterol efflux regulatory protein, can acquire cholesterol from peripheral tissues, deliver it back to the liver where it can be reutilized or excreted. There is an enzyme, cholesterol ester transfer protein. It's an enzyme that moves cholesterol from HDL to VLDL and LDL. So if you block this enzyme, you should get an increase in HDL and you should get a decrease in LDL. So 15, 20 years ago, the pharmaceutical industry said, we're going to get blockbuster drugs. We're going to block this enzyme and raise HDL and lower LDL. So probably the first one that was investigated to a substantial degree and reported in the literature, and this is in 2007, was torcetrapib. Patients were either continued on atorvastatin alone with placebo or atorvastatin plus torcetrapib. About a 20% reduction in LDL and a 50% increase in HDL. This is unheard of. Mean HDL levels got up to 80 milligrams per deciliter. I mean, this is amazing stuff, right? So, I don't remember which pharmaceutical company this was, designs and puts hundreds of millions of dollars into the Illuminate study, where patients at very high risk for heart disease, over 15,000, were randomized to atorvastatin or atorvastatin plus torcetrapib. And wow, HDL up 72%, LDL down 25%. There was a little price to pay. Systolic blood pressure up about 5 millimeters. Just over a year into this study, the Data Safety Monitoring Board terminates the study. A 25% increase in cardiovascular events and a nearly 58% increase in all-cause mortality that was statistically significant. Despite these changes, despite secondary endpoints, the drug fails. There are other inhibitors that are being tested. Anacetrapib and evacetrapib may still be undergoing testing. Dalcetrapib, and these don't tend to increase the blood pressure. They all increase the HDL. They all decrease the LDL. Dalcetrapib trials were terminated not because it caused harm, didn't cause harm, but it didn't cause benefit either. Didn't show any reduction in cardiovascular events. And it is possible that some of these drugs are still under investigation, but I think it's becoming increasingly clear that this class of drug is probably not going to be something that's going to help patients reduce cardiovascular disease. So I hope that I have convinced you, even though everyone hates lipid metabolism, that understanding lipid metabolism really aids you in guiding how to understand patients' problems and how to treat them. That the PCSK9 antibodies are very potent drugs. I expect they are soon to be approved for clinical use. I think it's going to be an important question where they fit into the paradigm, our current paradigm, of who to treat and when to use these drugs that I expect will be extremely expensive. The drugs that inhibit VLDL synthesis, mifemersin, lomidopide, can significantly improve lipid levels, but because of their toxic effects on the liver, are highly restricted to only those that have familial hypercholesterolemia, that are homozygotes, and I think it's unlikely, unless something can change on the toxic effects, which I think, based on the nature of how these drugs work, is probably not going to happen, not to be used particularly much. And lastly, that the cholesterol ester transfer inhibitors, while they have beautiful effects on secondary endpoints on the lipid levels, have not been proven to reduce heart disease, and in some cases actually increase it. So, questions, if anybody, or comments?
The injections were given by physicians, so they were given, some of them were patients used at home.
You know, I don't believe in the, I'm thinking back to the actual primary data that I read, that they mentioned that, but they were given often they were given every week or every 2 weeks, so I expect they were administered at home, but I can't answer that for you.
Most of this data is for a few weeks.
Yeah.
Maybe up to a year.
Up to a year. Yeah, most of it's up to a year. I didn't see anything past a year at this point.
We're talking about all these patients who require injections for the long term, which it comes out. So if some diabetic patients are already using injections, on top of that, they've been using every 2 weeks injections like this. So I was just wondering, if there are more data more beyond 1 year, are there any data?
I haven't seen, I can't recall a study where that went beyond 52 weeks. Most were 26 weeks. I can't recall any that I ran across, and I looked pretty hard in the recent literature up to a few weeks ago when I stopped looking. Okay. Any other comments or questions?